Hello, students. So welcome to this high-yield question session of anesthesia and emergency medicine. So welcome to this ALAN-NET session of anesthesia. In this session, I will discuss with you few very important questions which I expect to come in INI-CET. Well, INI-CET has a specific pattern and we see that they don't deviate much from their pattern. And I have picked up the most expected question, seeing their last few years question, plus the latest question which has been asked in various exams let's say last few years. So let us start with our first question. Now, first few questions I would discuss in this session would be on the clinical scenario, complication-based clinical scenario. Okay, so let us start with the first question. Okay, so our first question is, a patient developed severe hypotension, bronchospasm, and edema of upper airway after injection of radiocontrast medium during cerebral angiography. The most appropriate immediate treatment is administration of. Okay. Now, guys, just understand. This is a question based on anaphylactic reaction. Now, the scenario is describe a scenario of radiology scenario, right? What happens in radiology room, right? Contrast has been given, but this scenario, any scenario can be there. A scenario of ward, a scenario of OT, that a patient has been given some drug and the patient develops hypotension, patient develops bronchospasm and edema. Bronchospasm and edema. Got my point? Okay. So if these hypotension, bronchospasm and edema, these come immediately after giving some drug, what is this? What should we suspect? It is most probably life-threatening clinical manifestation of IgE-mediated hypersensitivity reaction, IgE-mediated hypersensitivity reaction. And most commonly, it starts within minutes or maximum to within 1 hour, that less than 1 hour of the exposure of the allergen. And it is more rapid after parental allergen. So here it was given injection, IV injection of radiocontrast, or immediately it appeared. There's a possibility, a clinical scenario, IM diclofenac was given and this hypotension, bronchospasm, edema appeared after some time. So IV within minutes and with other routes, less than in 1 hour, the clinical manifestation will come. So the question is, what is the most immediate management? So let us talk a little bit about the management of anaphylaxis. Remember, the first drug which you have to remember it in anaphylaxis management is your epinephrine, right? First drug. So how do we approach? If the manifestation is immediate and I can see that it is after giving some drug, like I'm giving a radiocontrast agent and this is appearing, immediately I will stop injecting the drug. Or let's say I have started antibiotic and this scenario came. I will immediately stop the antibiotic. So removal of the inciting cause, if possible. So we stop the infusion, right? Then as soon as possible, we give epinephrine. If patient has, let's say, IV line there, and the clinical manifestation is more life-threatening, then we can give IV also, but in maximum cases, we give the IM epinephrine. So in maximum cases, we give IM epinephrine. So I'll talk about the dose in a while. Okay. So we can give IM epinephrine. We can wait for 5 minutes. If the patient is not improving, I can give additional IM epinephrine. And if patient is not improving or deteriorating after my first dose itself, I will turn into IV epinephrine. Okay. There is no contraindication of giving epinephrine. There is no contraindication. Every patient can be given epinephrine. Okay. After giving this epinephrine, we try to keep the patient in, let's say, head down position and let's say lower limb elevated if the blood pressure is decreased. Or if the blood pressure is normal and patient has more respiratory manifestation, or if blood pressure is decreased and patient has a respiratory manifestation, then we cannot go make the patient in a supine and a low head position or lower limb elevated position. Then we have to keep the patient in sitting position, because let's say airway compromise can be life-threatening in these conditions. Okay, we immediately attach oxygen to the patient and we start volume resuscitation with IV fluids. So according to the manifestation, so remember in anaphylaxis, 3 systems is affected: cardiovascular, respiratory, and skin. Well, other system can also be affected. Nervous system can be affected. GIT system can be also affected. But remember, these 3 system manifestation will always be mentioned in the question. What they will write about cardiovascular system? They will write hypotension and cardiovascular collapse. So they will decrease blood pressure, and maybe cardiovascular collapse they may write a cardiac arrest happen after giving a drug. Okay. So cardiovascular compromise. Respiratory, what manifestation would it be there? Respiratory manifestation would be bronchospasm, respiratory distress and all. And what about skin? In skin, the manifestation would be flushing and urticaria. So mostly flushing and urticaria. Got it? So these manifestations would be there. And we start with the management with epinephrine and symptomatic management according to the symptoms. Volume resuscitation. If respiratory compromise is there, we secure the airway of the patient. Okay, now dose of adrenaline. See guys, it is not required to remember dose of every drug, but dose of emergency drugs can be asked in exam, and dose of emergency drug you have to remember. So IM dose of adrenaline which we use is 0.01 milligram per kg body weight. Well, if you have seen an ampoule of adrenaline, it is 1 milligram, 1 in 1000. Okay. And what we have to give to the patient, IM 0.01 milligram per kg body weight. So for a, let's say we load it in this 1 milligram, we can, let's say a little bit diluted, and in 2 cc syringe, we will take it. Let's say for 0.01 milligram per kg body weight, for a 60 kg patient, I have to give only 0.6. That is, of 1 milligram, I have to give only 0.6. So I take it in a 2 cc syringe and I just inject 0.6 of that adrenaline. In most, let's say, common site of injecting adrenaline IM is anterolateral thigh, anterolateral part of the thigh. So we go in thigh. Okay. If patient is not responding within 5 minutes, we can repeat the dose, 70% of this dose. So whatever I have given, 70% of that I can repeat again. If patient is not improving, then we give IV dose. The IV dose is 0.05 to 0.1 milligram IV bolus. So 1 milligram, 1 in 1000 is 1 ampoule. We dilute it by mixing 9 ml normal saline. Now it becomes 0.1 milligram. Okay. 0.1 milligram, 1 in 10,000 dilution. Okay. Now remember, for cardiac arrest, the entire 10 ml is given, but 1/10 of this dose is given in anaphylactic shock. So adrenaline IV, we give in cardiac arrest always IV, but in anaphylactic shock, most commonly we are giving IM, and if I am giving IV, 1/10 of the cardiac arrest dose is what we are giving IV. That is 0.05 to 0.1 milligram IV bolus. We can repeat every, let's say, 2 minutes, because half-life of adrenaline is 3 to 5 minutes. We can repeat every 2 to 3 minutes, and we can start an infusion if the patient is not improving. Okay. What is the effect of adrenaline in anaphylactic shock? Well, we all know that adrenaline acts on alpha-1 adrenergic receptor, beta-1 adrenergic receptor, and beta-2 adrenergic receptors also, right? It acts on alpha-1, beta-1, and beta-2. And by acting on all these 3 receptors, it improves the patient and in anaphylactic shock. It gives a symptomatic relief to the patient in anaphylactic shock. So if it is acting on alpha-1 adrenergic receptor, it is causing vasoconstriction. So it is causing vasoconstriction, increasing the peripheral vascular resistance and decreasing the mucosal edema of the patient. So blood pressure is being maintained and mucosal edema is being decreased. Okay. By acting on beta-1 adrenergic agonist receptor, it is acting on heart. It is increasing the heart rate and it is increasing the cardiac output of the patient. And by acting on beta-2 receptor, it is causing bronchodilation. It is giving relief from bronchospasm. So that's why adrenaline is drug of choice in anaphylactic shock. We start with IM, and if patient doesn't improve, we go to IV. What are the other treatments we do in these patients apart from adrenaline? Adrenaline is the first drug. What are the other drugs which we can give? We can give H1, H2 antihistaminic. Both are useful. H1 also, H2 also. So I can give diphenhydramine or cetirizine, right? Diphenhydramine or cetirizine to the patient. These are H1 antihistaminic. And for H2 antihistaminic, we can go for ranitidine or famotidine, any. So both are given, okay? We give bronchodilator if there is a bronchospasm. And now, what is the role of steroid? What is the role of steroid? Remember, steroid has no role in acute treatment of anaphylaxis. So steroid has no role in treatment of anaphylaxis, acute treatment of anaphylaxis. So it has no role. So where do we use steroid? We use it in preventing the second phase of anaphylactic shock. In acute phase, immediate, it has no effect, but it is used to prevent the second phase reaction of anaphylaxis. So it is just used to prevent the second phase reaction. Otherwise, in acute treatment, it has no role. So if a question is asked, all of the following drug is used in acute anaphylaxis except, and in the option is adrenaline, diphenhydramine, ranitidine, and methylprednisolone. Your answer has to be methylprednisolone. Methylprednisolone has no role in acute management. In acute management, it has no role. Okay? It has the role in preventing the second phase of anaphylaxis, right? In preventing the second phase. So let's say when we are shifting the patient to the ward, once the patient has been stabilized, we can give a dose of methylprednisolone to the patient. Okay? So this is the management of anaphylactic reaction, the first question which we discussed. So the most appropriate immediate treatment in this patient would be your epinephrine or adrenaline. So answer would be epinephrine or adrenaline. Got my point? So this is our first question. Now the second question which I want to discuss, again, a very important question, a question on complication. The question is, a 17 years old male underwent a nerve block with bupivacaine. So he was given bupivacaine. 5 minutes after the procedure, he reports some dizziness and appears agitated. What is the next best management? Now, mind you, just this kind of question lately is very much being asked both in NEET and INI-CET, that a local anesthetic like bupivacaine or lignocaine was given to the patient. And after that, patient had some manifestation, dizziness or agitated, whatever, right? Now, cardiovascular manifestation can also be there, whatever. So in this question, dizziness and agitation is there. And what is the next best thing? So what is this actually? This is local anesthetic systemic toxicity. The drug which was given for nerve block got systemically absorbed. So this is local anesthetic systemic toxicity. Local anesthetic systemic toxicity. So nerve block, the drug got systemically absorbed. And two systems can be affected. It can affect many systems wherever like local anesthetic can bind to the sodium channel, but the sodium channel mostly present on brain and cardiovascular system produces the clinical manifestation which we have to manage. So CNS symptoms and cardiovascular symptoms. CNS symptoms, what happens? Patient becomes agitated, right? Patient is uncomfortable, agitated, uncomfortable, as in our patient. Patient starts having perioral numbness. Patient starts having, let's say, perioral twitches, and seizure. Anything can happen. Patient starts having seizure. And if more drug is systemically absorbed, it will cause cardiovascular toxicity, in which patient can have hypotension, arrhythmia, and cardiac arrest. Anything can manifest. Hypotension, arrhythmia, and cardiac arrest. So what is the management of local anesthetic systemic toxicity? Remember, the management is symptomatic. Whatever symptom is coming, agitated, uncomfortable, we will monitor and reassure the patient. Perioral numbness, we will reassure the patient. Perioral twitches, we will little bit sedate the patient. Seizure, we will give anti-epileptic prophylaxis. Hypotension, we will start inotropes. Arrhythmia, we will give antiarrhythmic. Cardiac arrest, we will start CPR. So whatever symptom is coming, we manage symptomatically. Okay. And what else we can do? So what I'm writing, the management is symptomatic. Whatever symptom is coming, symptomatic. Okay. Whatever symptom is coming. So we manage the symptom. And we give one very important antidote, that is 20% intralipid emulsion. 20% intralipid emulsion. Now, what is the role of this 20% intralipid emulsion? What does it do? This intralipid emulsion absorbs the remaining local anesthetic in the blood and does not let it go and bind to the sodium channel of the organs, brain and heart further. So it absorbs the remaining local anesthetic in the blood. So this is helping in stopping further deterioration of the patient. So this is kind of antidote. This is always available whenever we are giving the regional block as a rescue therapy. But first management is always symptomatic. So if you read this question, in first look, the answer seems we'll go for the answer, place an order for lipid emulsion therapy. Well, but definitely we will go for lipid emulsion therapy, but that is not a priority. Patient is having some dizziness. Patient is saying he's lightheaded, dizzy, and patient appears little apprehensive. Okay, doctor, what are you doing? I'm not feeling good, little apprehensive. So what is the primary thing we do? We monitor the patient. If already monitor is not there, I place the monitor and place the pulse oximetry and monitor the patient, because if patient will deteriorate, we'll go for the symptomatic management. And when I do this, then I go for the, let's say, lipid emulsion therapy, right? We can go. If patient starts improving, I may not require a lipid emulsion therapy. Maybe a lot of drug has not been absorbed intravascularly. If patient has gone into cardiac arrest, if patient is having seizure, definitely I will start lipid emulsion therapy. But if patient is in initial phase, little bit uneasiness, dizziness, so mostly we have to just monitor the patient. So in this question, as it seems, the answer, place an order for lipid emulsion therapy, but that would not be answer, because next best step, you always have to read the question very carefully, right? Next best step in the management. Answer has to be place the cardiac monitor and continuous pulse oximetry and monitor the patient. So monitor the patient would be our option in this case. The answer has to be C. So a similar kind of question, next best thing, right? This is local anesthetic systemic toxicity. The rescue therapy is 20% intralipid, but that is a rescue therapy. We have to manage according to the symptoms, symptomatic as initial therapy. So next, for the question in next best thing, we have to see what is the symptom coming and we have to manage and monitor accordingly. A similar kind of question, a separate scenario, is the next question which I want to discuss with you. Okay. So the next question would be, a patient of road traffic accident with a lower limb laceration injury was brought to emergency. He was profusely bleeding from the injury site. He was responsive to pain. So the first thing which we got in the question, he was responsive. So he was responsive. His blood pressure was 80/50, heart rate was 144, and respiratory rate was 30. So patient is in shock, and we can see that he is bleeding profusely from the injury site. So I know why the patient is in shock, and patient has a lower limb laceration injury. The trauma patient, bleeding profusely, patient is in shock. So how we will approach this patient? Well, options are airway to be assessed and if required, secured. IV cannula to be secured and fluid started. Patient dressing at the bleeding site, immediate CT scan. Now, in first look, it seems that you should go for the answer. Stop bleeding from the bleeding side. Patient is profusely bleeding and going into shock. But what would be the first approach in any patient, in any emergency patient? You always have to be clear in that concept, and questions has to be answered with that concept. So if I get a patient, right? I get a patient. Patient is, first thing which I see in the patient, which is brought to the emergency, the response. So first thing we see is response. Our patient was responsive. Patient was responding to the pain stimulus. So patient was responsive. If the patient is responsive, then we go for ABCDE approach. A, B, C, D, E approach. Okay. A for airway. So any emergency patient comes to us, even if I can see that what is the issue in the patient, I would not, let's say, as an initial step, go to that issue, because life-threatening things can already be present in that patient. That is, airway may be compromised, right? So first, he may not be breathing properly. So first, I have to take care of the airway of the patient, right? Then I will have to see whether the patient is breathing or not. Breathing. Then I will come on circulation. And see, one by one, I'm seeing the ABCDE and I'm managing and preventing any life-threatening. If patient's airway is compromised and I'm trying to stop the bleeding of the patient, what will happen? Patient will go into respiratory arrest. So I don't want my patient to go into respiratory arrest. So I have to secure the airway first. Then I have to see patient is breathing or not. Already patient has a compromised breathing. Patient has come into the emergency. I am seeing that he is bleeding, but his respiratory rate is low. If I will not support the breathing, I will lose my patient by hypoxic arrest. Got it? Then I will see the circulation. Immediately I will put the IV line, start the fluid fast. I will measure the blood pressure, attach all the monitors. Then I will see the disability. Patient can aspirate or something, neurological issue. I will secure that. And now I see to the site where the patient is bleeding profusely from. So expose the patient, exposure. I see that patient is profusely bleeding from the site, where the injury site. Then I will stop the bleeding by putting a pressure gauge or whatever management I have to do, the definitive management in this patient. Got it? So in this question, what would be the first approach is the answer. What is the first approach is the answer. Answer has to be airway to be assessed and if required, secured, right? So this would be our answer. If you see the last question, what is the next best management? He reports some dizziness and appears agitated. What is the next best management? So what is the next management? You manage symptomatically. Place the monitor and monitor the patient. Right? You're getting my point? Okay. So always your approach for the answer would be like this. What would be the next step if they are asking? You have to go for next step, what you have to do in that scenario. If you are asking the best therapy, then you have to go for the best therapy in that scenario. So always read the question carefully. And INI-CET question, they're a bit tricky. And it seems when you're reading the question, there may seem an obvious answer, but read the question carefully, because I'm seeing they're a little bit twisting the question, as I will show you in the next question, how they are twisting the question now. Okay. Okay, next question, Asho. Let us first discuss another very important topic of INI-CET, which is so commonly asked in exam. A 5-year-old twin presents with acute appendicitis. Okay, he is scheduled for emergency appendectomy. His family history is that his twin brother, right, suffering from malignant hypothermia episode, right, and had a 2-week intensive care unit stay. So he has a brother in which there was an episode of malignant hypothermia when he was posted for some surgery. Now, but he recovered. Which of the following anesthetic agent should be avoided? So INI-CET, the next very important topic is your malignant hyperthermia. Okay. So malignant hypothermia, I'm expecting a question, and I think they can ask a question, right? So what is malignant hypothermia? Now, malignant hypothermia is a pharmacogenetic disease. That is a condition which is triggered with the exposure of some drug in presence of a particular gene. So it's a genetic condition. So one brother has, the other brother may have it. So it's a genetic condition and it is exposed with some triggering agent. So what are the drugs which trigger malignant hypothermia? Anesthetic agents trigger malignant hypothermia. Malignant hypothermia is a perioperative complication. It's a perioperative complication. It's a perioperative complication. Got my point? It's a perioperative complication. And what are the drugs which trigger? The most important drug triggering malignant hypothermia, you have to remember, is succinylcholine. Any question asked, the first drug which triggers malignant hypothermia, the most potent trigger of malignant hypothermia is our succinylcholine. Got it? So succinylcholine is most potent trigger of malignant hypothermia. Got it? Second, your halogenated inhalational anesthetic agent. Halogenated inhalational anesthetic agent. Halogenated inhalational anesthetic. Now remember guys, I am telling inhalational anesthetic, but halogenated, not non-halogenated. Inhalational anesthetic, when you have, I have discussed with you, I have divided it into two groups, right? One, which are liquid at room temperature, they are mostly halogenated, they are potent inhalational anesthetic agent. And what comes under it? Lot of drugs, lot of agent like halothane, right? Then isoflurane, then sevoflurane, then desflurane, they all come under halogenated inhalational anesthetic agent. Nitrous oxide is not a halogenated inhalational anesthetic agent. Xenon is not a halogenated inhalational anesthetic agent. So they will not trigger malignant hypothermia. And the third drug which is triggering malignant hypothermia is lignocaine. So this you have to keep on your fingertips. The drugs triggering malignant hypothermia. These are the only three group of drugs which triggers malignant hypothermia. So coming back on the question, which of the following anesthetic agents should be avoided? So anyone can give me the answer. Succinylsamide, succinylcholine is not in the option. So what should be the answer? Options are nitrous oxide, rocuronium, xenon, and desflurane. Well, rocuronium does not trigger, succinylcholine triggers. That is, the rocuronium is non-depolarizing. Very good, Mayur. The answer has to be desflurane. So desflurane, which is the halogenated inhalational, it would trigger malignant hypothermia. Okay, so this is the first type of question. The second type of question asked on malignant hypothermia, they will give a clinical scenario, the clinical based question, and they can ask you to make the diagnosis. What is the condition? Why? I mean, what is this particular condition? What is the complication happening in this? Or they can ask management giving a scenario. Got my point? Okay, so clinical features. I told you it's a pharmacogenetic disease. What happens when patient is exposed to these drugs? The gene gets activates sarcoplasmic reticulum, and it causes a huge release of calcium inside the cell, and that calcium that attaches to the cyclic GMP receptors and triggers the metabolism, makes the metabolism of the patient twice, thrice the normal. It brings the patient in a hypometabolic state. So clinical features are due to this hypermetabolism. Got my point? So clinical features are due to hypermetabolism. And because of hypermetabolism, cell starts breaking down. Because of this increased metabolism in the body, cell breakdown happens. So cell breakdown happens. Got my point? Cell breakdown. So hypermetabolism and cell lysis. And all the clinical features would be because of this. Because of hypermetabolism, metabolic cycle twice, thrice the normal. So metabolic byproduct also start getting produced in huge amount. So CO2 production is, carbon dioxide is a metabolic byproduct. So CO2 will increase, hypercapnia. And remember, this is again an expected question of exam. Early clinical feature of malignant hypothermia. Answer is hypermetabolism. This is the early clinical feature of malignant hypothermia. Got my point? So important, hypercapnia or hypercarbia. Okay. Then other clinical features of hypermetabolism, increased CO2, increased blood pressure, increased heart rate, increased temperature, hypermetabolic state. So hyperthermic reaction. So temperature, the core temperature will increase. It is called hyperthermia, but this increase in the core temperature is not something which is an early clinical feature. It is a late clinical feature. Got my point? Though it is called hypothermia. And why it is called malignant hypothermia? Because once hypothermia starts, every minute, 1 degree Celsius core temperature increases. So remember that increased temperature, though it's a late clinical feature, it becomes a very difficult situation to manage. And arrhythmia, because of all the things clinical feature which I just described. And because of cell breakdown, what will happen? Acidosis. Cell is breaking, so potassium comes out, hypokalemia. So remember another exam question, that electrolyte imbalance seen in malignant hypothermia. Answer is hyperkalemia. Okay, remember this. Then your myoglobinuria, rhabdomyolysis, and renal failure. Got my point? So these are the clinical features. Questions can be like this. Let's say 5-year-old child being operated in OT under halogen anesthesia, and suddenly his CO2 started increasing, blood pressure increased, heart rate increased, core temperature started increasing. What is the most probable diagnosis? Answer could be malignant hypothermia. Got my point? These are the clinical features you have to remember. If this happens, how would you manage? The next question is on management of malignant hypothermia. Well, management is immediately, again, that same question. So child was being operated under halogen. I have to stop halogen. So stop halogen. You stop halogen. Anything. I mean, I'm writing halogen because in my question, it was a halogen scenario, but anything. Stop triggering agent. Got my point? So stop triggering agent. Then let's say symptomatic management will start. But before starting treating the symptom, I will start an antidote, a drug of choice, dantrolene. Very important. What is the drug of choice in managing malignant hypothermia? Dantrolene. Dantrolene is drug of choice in managing malignant hypothermia. It stops the calcium release, so it stops malignant hypothermia. It's a drug of choice. And then we go for symptomatic management. Whatever symptom is coming, symptomatic management. If it is hypercarbia, I hyperventilate the patient. If it is hypothermia, I cool the patient. If it is arrhythmia, I give antiarrhythmic drugs. Okay, so this is the management of malignant hyperthermia. A very potential question of INI-CET, a topic of INI-CET. Got it? So this was our next question. Now let us talk another question. I told you, let's say recently a lot of questions are being asked on how do we manage a patient, let's say, who is not responding, responsive, unresponsive. So again and again, I'm repeating the same thing. I want this to be, let's say, instilled in your mind. So if any such question comes, you don't make a mistake. So my next question is, approximately 70-year-old male was lying on the middle of road, no response. So my second question was responsive person. The last questions which I discussed responsive. And now here there is no response on verbal and tactile stimulus. Patient was pulled and emergency was activated. So from lying on the middle of the road, he was pulled to the side of the road. So I did a scene safety because patient is unresponsive. I have to manage, but I have to first make the scene safe. Then I assess pulse and breathing. So if the patient is unresponsive, in responsive, we went for ABCDE approach. In unresponsive, we go for BLS approach. And what is the BLS approach? We assess pulse and breathing. Got it? We assess the pulse and breathing. So both pulse and breathing was present in our patient. So neither my patient was in cardiac arrest, nor my patient was in respiratory arrest. So what is to be done? So I have already activated the emergency. I will not leave my unresponsive patient and go away. Okay, he has pulse, he has breathing. Now I have nothing to do. No, guys. If he is unresponsive, you have to wait, hand over the patient to the, hand over the victim to the emergency system. Okay, or take the patient to the hospital, whatever, to the emergency of the hospital. So you cannot leave an unresponsive victim, even if he has pulse and breathing. So pulse and breathing is present, but he's not responsive. What will I do? I'm waiting for ambulance. Head tilt, chin lift. Well, this is done to open the airway. This is one maneuver to open the airway. Jaw thrust. Another maneuver to open the airway. Now, next, patient to be put in recovery position. Well, this is another maneuver which is used to open the airway and prevent any aspiration in a person. And in unresponsive person, right, with pulse and breathing. Patient is unresponsive with pulse and breathing. Patient is breathing. So maybe his airway is not obstructed. So head tilt and chin lift is not required. Jaw thrust is not required because these two maneuver opens the airway. Okay, opens airway. So these two maneuver is not required. What will I do? I have to just make sure that patient do not aspirate. So I will keep his airway open and prevent any aspiration to happen. So I will put the patient in recovery position. What is this recovery position? If you see this is a recovery position. Got my point, everyone? This is a recovery position. We take the patient, make the patient in lateral position, fold his one limb, upper limb, and place his other limb on the cheek and open his mouth, right? And one leg is again folded when the patient is made in lateral position. Okay, so this is the recovery position. This position, the mouth is open, patient is in lateral because one leg is folded, patient will not roll back, patient will remain in this, victim will remain in this, and victim will not aspirate. So we lay the victim on his back, place the right hand next to his head, place the left hand on his right cheek, hold the left shoulder and left leg and pull the body towards ourselves, rolling the patient on our side. And then patient head, let the patient head move little backward to prevent any aspiration to happen. Okay, so I make the patient in recovery position. And if you see this is the BLS protocol. In BLS protocol, this patient was unresponsive, no response. Patient had no response. Patient had no response, but patient had pulse and breathing. So in BLS approach, we verify the scene safety. It happened on the middle of the road. So what did I do? I pulled the patient to the side of the road. So I did scene safety. Then I called for help, I shout for nearby help, activate emergency. And then after that, what do? I check for pulse and breathing. So call for help and then I check for pulse and breathing. Patient has normal pulse and breathing, as in our patient. Patient had both pulse and breathing. So what do? I monitor until the emergency responder come by making the patient in recovery position. Okay. So I make the patient in recovery position. Got my point? So this is the BLS protocol which we have to follow in this patient who has pulse and breathing. Now, next question. A 35-year-old gravid patient with preeclampsia was on magnesium infusion, right? Magnesium is the therapy to prevent eclamptic fit to happen in preeclamptic patient, drug of choice. Now, but magnesium can cause in overdose. If increased serum magnesium happens, it can cause respiratory depression. So when the resident was taking round, she came to the patient. The patient was unresponsive. Again, the patient is unresponsive, like our previous question patient. Patient is unresponsive. Pulse and breathing was assessed. Pulse was 58 beats per minute, but there was no chest movement. So this is a probability that because of magnesium toxicity, the patient respiratory depression has happened. So patient is unresponsive with no breathing. If I see the BLS chart. So again, the resident was taking the round, so it was a safe situation. She will call for help and then she will assess pulse and breathing. Pulse is, let's say normal pulse is there, but there is no breathing. No breathing and pulse is there, right? So this is patient is in respiratory arrest. Respiratory arrest. So there is no pulse. Sorry, no breathing, not pulse is there, of course. No breathing. Okay. No breathing. Magnesium toxicity has happened. And pulse is present. Pulse present. So what we will do? We will give rescue breath. So we will provide rescue breath. So what is the correct option in this? What should be done immediately? The question is asked, right? Rescue breath to be given. 10 breath with ambu bag. Okay, we'll bring a manual resuscitator, popularly called ambu bag, and we'll give 10 breath per minute. In adult, the rescue breath. In rescue breath, you have to remember how many rescue breath is given. You know, this chart is very, very important. Every point of this chart has been asked in exam. What is not asked, what I'm expecting as a next question is I'm telling you. They can ask the rate of the rescue breath. So rescue breath, the next time in exam, the question can be. So if it is adult, 10 breath per minute. That is 1 breath every 6 seconds. Okay, 1 breath every 6 seconds. If it is pediatric, okay. If it is pediatric, 20 to 30 breath per minute, right? That is 1 breath every 2 to 3 seconds. Okay, so I've written it in both ways. Remember it, that this rescue breath, you have to remember, this is fixed and you have to give an answer if it is asked like this. Okay, how many rescue breath? Remember like this. Okay, now if this patient, see, if this patient has pulse 58 beat per minute, but no chest movement. If this patient had no pulse and no breathing, no pulse, no breathing, then we would have started the CPR. So no pulse, no breathing, then we would have started cardiopulmonary resuscitation. Cardiopulmonary resuscitation. So what we do in it? We start with high quality chest compression. Chest compression and ventilation. Chest compression and ventilation. Got my point? And if it is shockable rhythm, defibrillation. If it is shockable rhythm, then we go for defibrillation as soon as possible if rhythm is shockable. Remember, if the rhythm is shockable. So when AED comes, immediately we have to attach. If the rhythm is shockable, as soon as possible, we attach and we defibrillate the patient. Got my point? So remember, this is the management of cardiac arrest. No pulse, no breathing. Okay. Yes, Samir, you are right. It is CAB for cardiac arrest. And what about, Samir, can you tell me, what about trauma patient? Trauma patient who is responsive. If someone becomes unresponsive, he is in cardiac arrest, she is in cardiac arrest, the management would be CAB. And if it is trauma, then if it is trauma victim, Samir, what do we say? Then in trauma victim who is responsive, we don't go for CAB. In trauma victim who is responsive, we discussed the previous scenario, ABC, airway, breathing, circulation. Got it? So responsive patient, trauma patient, responsive, we go for airway, breathing, circulation. That is the ATLS guideline. And ACLS guideline says in cardiac arrest, we go for compression, then airway and breathing, ventilation, right? Compression and ventilation. Got it? Okay. Okay, guys, next question. Again, a very important topic. And again, every YouTube session also I discuss this. And I will go on discussing. I will not stop discussing it because I'm not stopped seeing that questions are not, question has been stopped from this topic. If question will be stopped from this topic, I will also stop discussing. I don't want you to make a mistake in this topic, and that is oxygen therapy. So question on oxygen therapy. Oxygen therapy. Okay. Oxygen therapy. Okay. A 48-year-old patient with fever, upper respiratory tract infection was brought to emergency. His respiratory rate was 40 beats per minute. Supplemental oxygen was required in this patient, the most appropriate oxygen device. So device we will talk about. Now, let us just keep this question in mind, right? So Manish is asking from me, that have I left Prep Ladder? Yes, Prep Ladder was the previous platform on which I worked. Now I have joined Alan. So if you want to listen to my lectures on anything, you'll have to go for Alan next. So I have found I have found a better platform. I hope you also do the same. Okay, guys. Okay, coming back on oxygen therapy. Well, any question asked on oxygen therapy, you will have to remember that oxygen therapy, the device is divided into two types: low flow, variable FiO2 delivering device. Low flow variable FiO2 delivering device. Now, I will explain a very important point in this. Please try to listen carefully. Variable FiO2. What do I mean by this? I mean by this that oxygen concentration, which we want to give, oxygen concentration cannot be fixed. Oxygen concentration cannot be fixed, right? Whatever I want to give, 20%, 30%, 40%, it cannot be fixed in this. Got my point? In low flow variable FiO2 delivering device. In this, oxygen concentration depends upon patient's breathing pattern. Depends upon patient's breathing pattern. So if patient is doing a shallow breathing, right? If patient is doing a shallow breathing, not let's say normal rate is not there, patient is taking a very high respiratory rate, very low tidal volume. So a lot of air dilution from atmospheric air is happening in the device. So FiO2 of delivered will be decreased. So whatever FiO2 I want to deliver, I won't be able to deliver that. So that's why these devices are called variable FiO2 device, variable FiO2 delivering device. Got my point? Variable FiO2 delivering device. In this comes our three devices. Our normal nasal cannula, normal, or it is written nowadays conventional cannula, nasal cannula. So our conventional nasal cannula, then simple face mask, okay? Then your face mask with reservoir bag. That is Samir wrote NRBM. Face mask with reservoir bag. Got it? Reservoir bag. Got my point? That is NRBM, non-rebreathing mask. Face mask with reservoir bag. These three important devices, keep in mind for low flow variable FiO2. Now, these three devices, the FiO2, oxygen concentration, depends upon the patient's breathing pattern. So it is not independent of the patient breathing pattern. Now, last FMG clearance exam, the question was asked, which of the following device will give FiO2 from 0.25 to 0.45 independent of the patient's breathing pattern? Now, these cannot be the answer because these device depends upon the patient's breathing pattern. They are dependent on patient's breathing pattern. They are not independent of patient's breathing pattern. Got my point, everyone? So keep this in mind. These devices are dependent on patient's breathing pattern. Got it? So that these devices cannot be the answer in that question. Now, the next important thing is low flow. These devices, they are also called conventional devices, and they cannot give flow more than 15 liter per minute. They give maximum flow of 15 liter per minute. So oxygen flow given through these devices, maximum is 15 liter per minute. We cannot go beyond 15 liter per minute. So they are called low flow devices. Now, in this question, patient has a breathing pattern for shallow breathing pattern, and breath is 40 breath per minute. Our normal respiratory rate, 10 to 15 breath per minute. And when I am taking a normal respiratory rate, our inspiratory flow, normal inspiratory flow, how much is? It is hardly 6 to 8 liter per minute, right? Maximum 15 liter per minute, right? So if I have a normal respiratory rate, 10 to 15, 6 to 8 liter per minute is the inspiratory flow required. Little bit respiratory rate increases. Let's say from 15, it has become till 25 or 30 breath per minute. So little bit inspiratory flow requirement will increase. It will become 15 liter per minute, 15 liter per minute. So till 25 to 30 breath per minute, low flow devices can supplement in the inspiratory flow. They can contribute in the inspiratory flow. So low flow devices would be preferred. But if patient has a high respiratory rate, and if I attach these low flow devices, then it will not meet the inspiratory flow demand of the patient, and patient will fatigue. Right? Patient will have more shallow breathing and patient will fatigue, and they will also not deliver the required FiO2. So these devices cannot be used. So Samir, you answered NRBM, but this would not be the answer in this case because the rate is very high. And if the respiratory rate is 40 breath per minute, we need a high flow device. We need a high flow fixed FiO2 delivering device. Fixed FiO2 delivering device, right? Delivering device. And in this, two important devices you have to remember, which is asked in exam: Venturi mask or Venti mask, and your high flow nasal cannula. High flow nasal cannula. These are the two most important devices you have to remember in high flow. Guys, both the devices, Venturi mask and nasal cannula, can give inspiratory flow up to 60 liter per minute, right? They can give inspiratory flow up to 60 liter per minute. Imagine the low flow devices were giving only 15 liter per minute, and high flow devices are giving 60 liter per minute, right? So they are high flow. They will supplement in the oxygen requirement. And when patient is in respiratory distress, as our patient is with breath rate 40 breath per minute, I would require to attach a high flow device. You attach an oxygen delivering device for two things: to give FiO2 and to supplement in the inspiratory flow. So low flow device, if can give FiO2, the NRBM can give a very high FiO2, but it cannot supplement in the inspiratory flow, which is required in this patient. So NRBM will also not deliver the required FiO2. It will be diluted because of the shallow breathing by the patient. So NRBM will not be the good device. So in this, I would go for high flow nasal cannula. So answer would be B, high flow nasal cannula. Right, Samir? Answer would be HFNC. Very right. Okay. So very quickly, just few devices. This is what is this? This is a simple nasal cannula. Simple nasal cannula. What is the flow rate we have to keep in this? We start with 2 liter to 6 liter per minute, asked in exam. And what is the FiO2 achieved if the patient has a normal breathing pattern? From 0.22 to 0.45. So these three questions, potential question. Then the next one is our simple face mask. Simple face mask. Got my point? Simple face mask. What is the flow rate we have to keep, the oxygen flow rate in this? We start with 6 liter, 6 to 10 liter per minute. And what is the FiO2 which we achieve? The FiO2 which we achieve from 0.33 to 0.6, 33 to 60%, 0.33 to 0.6. That is 30 to 60%. Okay. Then comes, this is Venturi mask. NRBM image I have not given. You have seen so many times. NRBM, this is a simple face mask. Sorry, this is a NRBM. Sorry. This is NRBM because here a bag is attached. If this bag was not attached, it was simple face mask. But with this bag attached, it is NRBM. Got my point? This is NRBM. In NRBM, we keep the flow rate 10 to 15 liter per minute. And FiO2, we achieve very high FiO2, 0.7 to 0.9, 90% FiO2. But what is the thing which is required in these devices? Patient should have a normal breathing pattern, not more than 30 breaths per minute. Then only these devices can be attached. So this is Venturi mask. Venturi mask. Remember, it will have a Venturi barrel attached with it, right? And it is color coded. This would be color coded. And on every Venturi barrel, the flow rate required will be written, and FiO2 it will achieve will be written. Like for example, the barrel which is coded green color. It has flow rate, we have to keep it in 15 liter per minute. And FiO2 which it will achieve would be 0.6, that it can give 60%. Your Venturi mask cannot give more than 60% of oxygen. This is one demerit, but it is a high flow device. You give a flow rate of 15 liter and it entrains the room air and make the flow total 60 liter per minute. So it's a high flow device, okay? And this is HFNC. HFNC, high flow device, one of the best high flow device, right? Best high flow device. In this HFNC, the flow rate we keep whatever. We can start with 10, we can go up to 60 liter per minute, right? And FiO2, it achieves from 0.2 to 1, that is 100%. That is, we can give room air only 21%, and we can make it only 100 to 200% oxygen also. So everything is under our control in HFNC, high flow nasal cannula. So remember these 4 devices. Got it? Right. So Samir has remembered the color coding for all the Venturi barrels. Very nice. But I think just keep in mind, there are a lot of things we have to remember. The green one, I expect a question can be asked on green colored barrel only. Got my point? That is like kind of most expected and most commonly used Venturi device, the Venturi mask with green barrel. Okay. Okay. So green barrel, you cannot miss. You cannot afford to not remember, right? I mean, you can afford to not to remember. Got my point? Okay. Next question. A question on let's say ventilation, ventilatory parameter setting. Question is, a 60 kg female presented with acute respiratory distress post pancreatitis. So she has pancreatitis and she's now presenting with ARDS kind of phenomena. So she was put on mechanical ventilation and the setting was done. We put the patient on mechanical ventilation. We do the setting. Let's say tidal volume 450, respiratory rate 12 breaths per minute, IE ratio, inspiratory expiratory ratio 1:2. That's the commonest one we choose. And P, positive and expiratory pressure 5, and FiO2 of 0.8. That is 80% oxygen I am giving. Then after half an hour, after putting the patient on ventilator, we get an ABG done. So ABG showed pH within normal limit, PaO2 less, hypoxemia, and PCO2 39, that is within normal limit, 35 to 45. And HCO3 normal, and obviously saturation was less because PaO2 was less. So this patient is in hypoxemia. So patient oxygenation has to be improved. Okay. Why do you put a patient on ventilator? Why do we put a patient on ventilator? Basic, because of 2 things. See, ventilation, we're putting someone on ventilator, let's say is a therapy which we are giving till the primary disorder of the patient improves. So putting someone on ventilation is supporting the oxygenation and the ventilation of the patient, supporting the oxygenation and ventilation of the patient for the time being till the primary pathology improves. So ventilator supports oxygenation and ventilator supports the ventilation of the patient. If patient is not breathing properly, is in distress, so oxygenation and ventilation. So I have to make the oxygenation normal. How do I make the oxygenation normal? Now, there are 2 ways of improving oxygenation of any patient. By increasing the oxygen concentration of the patient. See guys, we are breathing room air, only 21% oxygen. If our ABG is done, our PaO2 will be 90 to 100 mm of Hg. If I start breathing 100% oxygen and then my ABG is done, my PaO2 will become 400, 500. So by increasing the oxygen concentration, I will improve the oxygenation. So my patient, FiO2, the oxygen concentration which I was giving was 0.8. We were giving 80%, which is a high oxygen concentration. And the second thing, by applying PEEP, we can improve the oxygenation by applying PEEP. PEEP, positive end expiratory pressure. PEEP keeps the alveoli. Our PEEP is, when we are breathing spontaneously, FRC, functional residual capacity. That is the volume above which inspiration, expiration happens. PEEP is an additional FRC which we give to our patient. So this is alveoli, right? If I have applied PEEP, the alveoli will not collapse because of this end expiratory pressure. It will remain expanded. And O2-CO2 exchange will happen, right? Through this expanded alveoli. So what will happen? Oxygenation will improve. So by applying PEEP. Now both giving high oxygen concentration has its complication, and high PEEP also has its complication. So in our patient, the PEEP was 5 mm of Hg. This is basic PEEP. This is not a high PEEP. This is the PEEP we start on ventilation, right? So in this patient, already FiO2 was high, 80%, giving FiO2 more than 0.6, that is above 60%. For more than 48 hours, oxygen toxicity can happen, right? So we have to keep it below 60% if possible, if we are able to maintain the oxygenation of the patient. So already I'm giving 80%, already high. So what is the other thing which I can do? I can increase the PEEP. So in this question, where oxygenation is affected, patient is in hypoxemia, how would I improve the oxygenation? By increasing the PEEP to 8. Yes. Okay. So B would be the answer. Answer of this question would be B. Got my point? If in the same question, instead of decreasing PaO2, they had increased PaCO2. In the same question, if I'm changing two things only, PaO2 is 70, right, mm of Hg, and PaCO2 is 60. So PaCO2 has increased, hypercarbia. So now I have to improve the ventilation. How do I improve the ventilation? I improve the ventilation by increasing the minute ventilation of patient. So by increasing minute ventilation, Got my point? So by increasing minute ventilation. How do I increase the minute ventilation? By two things, tidal volume and respiratory rate. By increasing the tidal volume of the patient and by increasing respiratory rate. So if PaCO2 is increased, I will increase either respiratory rate or I will increase the tidal volume to increase the minute ventilation. These setting change which I will do in this patient. Got it? Okay. Now coming on the next question, last question for the session. A 32-year-old woman is anesthetized for suboccipital craniotomy. So first thing, it's a neurosurgery. Okay. During positioning, the capnograph shows an abrupt decrease in slope of the expiratory upstroke. Which of the following is the most likely cause? Which of the following is most likely cause? Well, in first look, it seems the answer of this question would be that air embolism. Why? Because there is an abrupt decrease in your EtCO2. We have discussed so many times this favorite topic of INI-CET, that there is a sudden fall of CO2 in capno, right? And when you see the sudden fall, go for the answer air embolism. I have myself. But just one more important thing. See, this session I have specially planned for you that if there is any trick in the question, don't fall for the trick. So in this question, during positioning, surgery is still not started. Then how can air embolism can happen? Until and unless venous sinuses are open, air cannot be embolized. It cannot be embolized. So it cannot be the air embolism. So what has happened during positioning, the capnograph shows abrupt decrease or becomes zero. That's also possible during positioning. Then it would be, if it becomes zero, then it becomes accidental extubation. The tube has come out. And if it has decreased suddenly, then maybe an absolute obstruction has happened, right? Absolute obstruction has happened. So ET tube must have kinked, right? ET tube must have kinked. Absolute decrease is happening, right? So kinking of EtCO2 would be the answer in this question. Why? Because this is happening during positioning. If the same question, a 32-year-old woman is anesthetized for suboccipital craniotomy, after starting the surgery, after 2 hours, there was an abrupt decrease in capno. After surgery, in mid of surgery, this kind of question. Then what is the most likely cause? Then blind answer, air embolism, nothing else. You have to go for air embolism. Got it? But during positioning, abrupt decrease or zero, EtCO2 becomes flat. Then answer would be accidental tube has come out or circuit disconnected while positioning. So, right? Or it has sudden decrease, that EtCO2 has kinked. Got my point? So answer would be D. So there is a possibility the question can be tricky. So just read the question carefully. Careful reading of question is must, even if it seems that it's a repeat question and you know the answer. They can little bit twist the question. Got my point? So answer is kinked ET endotracheal tube. See guys, sudden decrease of EtCO2 or EtCO2 becoming zero, right, during positioning, etc. The answer has to be accidental extubation, or circuit disconnection. Got it? Accidental extubation or circuit disconnection. Okay. Sudden decrease in EtCO2. Sudden decrease in EtCO2 in mid-surgery, during procedure, in mid-surgery, right? Sudden decrease, sudden fall in mid-procedure. Answer has to be air embolism. Air embolism. Now remember guys, air embolism, very most common in your neurosurgery. So air embolism, 4 or 5 points I want to talk. More common, most common. The incidence is most commonly seen in neurosurgery. So air embolism is something I am talking about. The last thing for this session, and that is it is seen most commonly in neurosurgery. Right. Now, the most sensitive monitor to diagnose intra-op air embolism. Most sensitive monitor, right, to diagnose intra-op air embolism. Monitor for diagnosing intra-op air embolism, right? The answer has to be transesophageal echocardiography. Transesophageal echocardiography. Transesophageal echocardiography. T. So T is the monitor which is always attached in those surgeries where we suspect a high risk of air embolism, right? Like your sitting craniotomy, posterior fossa tumor surgery, etc. Keep it in mind. These are very popular questions of air embolism. The clinical scenario, mid-surgery, sudden drop of EtCO2. Answer has to be air embolism. Then most commonly air embolism is seen in neurosurgery. It can happen in any surgery, but most commonly in neurosurgery. And the most sensitive monitor to diagnose air embolism, transesophageal echocardiography. Okay. So this was my last question. And whatever question I discussed, I expect that definitely I pray that definitely the question will be asked from this. And these are really very important. My bad luck if the question is not asked from these topics, but these are really important topics. You cannot afford not to study and go for the exam for these topics. Got my point? So thank you so much. Thank you for your patient listening. And so thank you guys. And let's hope to meet soon. And best of luck for your exam. Bye.